My name is Dr. Edward Ngwenya, and we continue with our series on breast. Herein, we'll try to have a short, talk. I'm not going to be as detailed as I've been with other presentations, but it's something that you can read up, and get an understanding. This is regarding congenital breast deformities and other abnormalities that we get in females, which we have not necessarily discussed. And the focus perhaps can be Poland's syndrome. Just to be aware of that, and we'll just quickly touch on it. I'm not going into detail because we actually go relatively deep into it when we discuss our topic, and I'll refer you to our chest wall deformity, our chest and trunk series, where we discuss Poland syndrome very much into detail. So this, I'm just gonna quickly go over it. Tuberous breast deformity, something that we should know about. Another thing perhaps should be breast or rather hypertrophy, nipple hypertrophy, and also an inverted nipple. These are some of the things you may get. Giant fibroadenoma, something to know about. And maybe last I may just put in something, that may come through known as Mondor's disease. Just to understand that. So let's be fast and go into it. So Poland syndrome, perhaps let's quickly get that out of the way, described by Alfred Poland in 1841. He was an anatomy demonstrator actually at Guy's Hospital in London, and he described this and said it's characterized by unilateral left, I say left, unilateral chest wall and upper limb abnormalities. So generally you have an underdevelopment of the pectoralis margin muscle, the sternal head, which is the sine qua non of it, in combination with webbing of the fingers in the ipsilateral hand, which can be either complete or incomplete. So there are variable manifestations of this, from mild to moderate. Something that, if you compare, more males will present with Poland syndrome. It's about a 3-to-1 ratio. However, we get more females that would seek treatment because of breast asymmetry, but something not so common, 1 in 30,000 births, and the right side is actually affected twice as often as the left side. So right side more common. And etiologically, we don't really know in details, but the most popular theory is vascular, basically. It's the subclavian artery disruption sequence. And so what you get in the 6th to the 7th week of intrauterine life, that's critical period, you get vascular compromise. And so what that would also lead to is anything on that side of the subclavian to be hypoplastic. Growth of ribs drives the subclavian artery to become, hypoplastic. And we've seen that this, maybe to support this, there's a 2 times increased risk in children whose mothers actually smoked during pregnancy. So there are various components. There's the chest wall. I don't want to go into it a lot, but the absence of the sternal head of the pec major is actually, the sine qua non. There are limb abnormalities. There's cardiovascular abnormalities such as dextrocardia. You may have hypoplastic or absent vessels. And so these you need to think carefully, especially when thinking of breast reconstruction, because the thoracodorsal or thoracoacromium subclavian side there may actually not be there, and so leads you in a bit of problems when now you want to raise a latissimus dorsi. There are renal abnormalities such as hypoplasia, duplication of the collecting systems, but there are other abnormalities you can get, spherocytosis. There is an increased incidence of leukemia and even Mobius syndrome, which is your facial porcelain and abducent or cunipalsy. So these are just some of the things you'd have. I'm not going to go to the classification, but there's the 4-CREST classification, where you classify it grade 1, grade 2, grade 3, grade 1 being minor, grade 2 moderate, and grade 3 being the severe deformity or aplasia of the breast and the pec major, and also the major chest wall deformities that you would get. But generally, indications for treatment in these patients would be, patients who've got absent ribs, and in this talk mainly it would be females with breast asymmetry. Males generally, chest wall contour deformities, but females mainly is this breast asymmetry that they would present. So when you see a patient, you want to make sure that you exclude this. And you'll be told that the best time for surgery is in the late teens. But look, some operations have been done and performed as early as 11 to 12 years of age and onward. But, you kind of maybe might be prudent to delay it after puberty, where it can assist with a patient who's, socially psychosexual growth and, has that form of understanding, and you are able to symmetricize your breast accordingly. So, and the options are vast. I'm not going to go into that, but expander and implant reconstruction, you can go for autologous tissue, you can go for autologous fat injection, which, are more recent fat transfer techniques that have been applied using the Coleman's technique. So, and also there are also alloplastic meshes and custom fabricated silicone moulages that one can use to correct the deformity. So that's Poland succinctly. Now, what other pathology can we have? Tuberous breast deformity. Very important to know. And how do we define a tuberous breast? And those are the questions you'll be asked, how do you define, what are the anatomical abnormalities of a tuberous breast? And what maybe I may say, let me just give you a few. Remember, you may not necessarily have all of them. You may have part of them. You may have just a few of them, but these are the anatomical characteristics. You need not have them all. So it's a deficient, basically there's deficient breast development in vertical and horizontal dimensions. So how does that manifest? You've got a constricted breast base or a narrowed breast footprint, basically. So there's constriction in the base. This is not just limited to the base. There's constricted, or rather a contracted skin envelope in both vertical and horizontal dimensions. You've got hypoplasia of the breast parenchyma. You've got an elevated IMF. You will have a short NAC to IMF distance. In other words, you have a high tight fold. And because the parenchyma is hypoplastic, but it's all lying lower down in this contracted skin envelope with a constricted base, you then have herniation or pseudoherniation of breast parenchyma into the NAC. So those are the main things: constricted base breast, breast base, a narrowed footprint, contracted skin envelope, both horizontal and vertical dimensions, the parenchyma hypoplastic, an elevated IMF, and herniation or pseudoherniation of breast parenchyma into the NAC. Now remember, I said you may not necessarily and you need not have it all, but you can have just some of it. Now, the etiology is unknown, and that's all I'm going to say. It's unknown. However, there's been many proposed, theories as per Grolio, and I think it was Mandrekas who proposed also his theory. I think Grolio said he proposed an anomalous superficial fascial adhesion between the dermis and the underlying muscular plane. And so goes further by saying these adhesions actually restrict normal breast development of the parenchyma and the overlying skin envelope in the lower pole. And so this type of restriction favors growth of the breast away from the chest wall, leading to the tubulous shape formation and actually the herniation or the enlargement of the areola as the breast develops during adolescence. That's one of the thing. I think Mandrekas, he says, look, the deformity actually, it's not just one thing, but it's a combination of things, a combination of abnormal constricted fibrous ring surrounding the periphery of the NAC and actually a normal superficial window beneath the areola. So he reckons that, look, the superficial layer of the superficial fascia is actually absent in the area underneath the areola. And so that's why you then get that pseudoherniation there. But these are just some of the things that are proposed as per etiology. The important thing is to classify. He classifies, using grade 1 to grade 3. I personally like to use the von Henberg classification that classifies it into 4. And in essence, I would encourage you to have a look at some pictures, but type 1 just says there's hyperplasia where in the lower medial quadrant. Type 2, there's hyperplasia not only in the lower medial quadrant, but also in the lateral quadrant. But there's sufficient skin in the subareolar area. Type 3 says there's the hypoplasia in the lower medial and lateral. However, there's deficiency of the subareolar skin. And then, of course, type 4 will say, look, this is severe breast constriction with minimal breast base, this being the most severe. Grelot, which simplifies the von Henberg, just simply combines type 2 and 3. All that classification says is type 1, there's lower medial quadrant deficiency, the same as type 1 in von Henberg. But type 2, it says there's lower medial and lateral quadrant deficiency. So it just puts those up, but it does not divide them based on the subareolar skin sufficiency or deficiency. And then type 3 says, look, there's deficiency in all 4 quadrants. It's just a simplified version, which is easy to understand. And so I think the next thing then would be to manage, because the patient comes in and wanting management. And how are you going to manage? You need to have goals. Remember, we've defined the anatomy. So now we want to address those or that abnormal anatomy. So our treatment goals are what? We want to expand the breast circumference. That's numero uno. Then we want to expand the skin envelope in the lower pole. We want to increase breast volume when appropriate. We want to reduce the areola size and correct the herniation that's there. We also want to release constrictions at the breast, areola junction. And then we want to lower the IMF if it's high, and we want to correct the nipple location and the breast ptosis. So those are generally our goals. You just need to know the anatomy and to know now and work in reverse into what you then want to do. I'm going to just be high level in giving the treatment goals, or rather the treatment. If you have a constricted skin envelope, this is what's going to limit the final volume of the breast. And it also means that the IMF is generally abnormally high. So for mild forms, this you can manage primarily by placing an implant. Others would say, no, we need to stretch it a bit further, especially if the skin envelope is tight and the IMF is high. So we can stretch it and lower the IMF over time using a tissue expander. So those are your options. Now, you need, of course, to break those constrictions. And then, as it says, the option is for the skin envelope, you can then put in an implant. Now, for the pseudo herniation, what you need to actually do, and what you must be aware of is that when you reduce the areola size in a patient with pseudo herniation, it actually has the effect of evenly distributing the forces of the underlying breast tissue, where on the entire skin, as well as adding that symmetry to the breast appearance. So for this, you want to have at least some guidelines as per diameter that you aim for, which is 4 to 4.5 centimeters. So those will be your targets generally, and you want to match. I'm not saying strictly stay on those measurements, but what you want to do is to match the contralateral side. But if unable to, you aim for that normal 4 to 4.5 centimeters. But generally, you want to reduce that. As per breast volume, I think we've addressed some of the things. You want to treat, of course, always the more severe side before you go in and symmetrize. So you aim, to treat the more severe side first, usually the tuberous side, and then you will follow at a later stage with symmetrization. Now, there are arguments, should you do it immediate, reconstruction, or should you stage it? Immediate reconstruction, of course, the areola technique that you can use. There's the implant technique that you can use, and they have their pros and cons. But you should know that you can also do it in a staged manner, and generally, indicated in those patients who will require additional volume. But the problem is that their skin envelope is inadequate to accept, the suitable size of implants that they want. That's your grade 3 and grade 4 tuberous breast. So these ones you would want to stage them, with tissue expansion to prepare the sufficient size implant pockets that you will generally need in future. I think that should suffice in assisting you to treat or to manage a tuberous breast. And I think, we need not go further into tuberous breast. So something simple to be able to then manage. Recognize, know the anatomy, be able to manage. There's giant fibroadenoma. It's a patient who presents fibroadenoma greater than 5 centimeters, large there. And what you generally want to do, like vaginal hypertrophy, it's thought to result from abnormal sensitivity of the breast tissue to normal hormonal levels, actually. So for this, it's quite benign, and we want to, surgical excision then is the treatment of choice. And you may find it very challenging in certain patients where it's so large, and so you need to then see how you can do a mammoplasty on one side, maybe on both sides even, but the one side you've just got these fibroadenomas which complicate your pedicle, and you really sometimes have compromised NAC secondary to that. But I've seen also that really you can really thin your pedicle and really get away with it if you do it meticulously, of course, knowing your blood supply, and actually not go for free nipple graft in all cases of just fibroadenomatous breasts, but you may be able to manage that with your normal breast reduction procedures. Nipple hypertrophy, quite uncommon, and it has quite a strong familial tendency. Generally begins after puberty and intensifies with pregnancy, and it enjoys past menopause. And what you generally find, it's quite independent of breast size. And so there's a lot of literature written about this. Regnold himself, reviewed the treatment, and he proposed correction by cylindrical resection of skin and hypodermis, and leaving the duct intact. And that's something that can work. There's work by Spelly, who described a complex technique for functional reduction of the nipple height and the diameter. Again, the diameter in this instance, or the duct in this instance, is also preserved. So there are various techniques. Just familiarize yourself, at least be able to do one. But there are ways of reducing it. It's a very simple way, actually. You just, circum in nipple incisions there, and then you just de-epithelialize, if you may, and then you just close it. So nothing big, and you keep the duct intact. Another thing you may be confronted with is a nipple that is inverted, and up to 10% of the female population actually have a flat or an inverted nipple, and this can present either unilaterally or bilaterally. But most commonly, congenital. It can be still secondary to other things such as macromastia, mastitis, breast reduction surgery, cancer, etc., etc., etc. But this can be a cosmetic concern for females, and it may interfere with, even other functional abilities in terms of breastfeeding. So what you generally need to do is to classify, and we've got in 1999, Han and Hong described a grading system of the inverted nipple. And generally, it was grade 1 to grade 3. I'll quickly go through it. Grade 1, the nipple can easily be pulled out manually. And when you pull it out manually, it maintains its projection without traction. So these patients generally have minimal or no fibrosis. There's no soft tissue deficiency. There's normal lactiferous ducts. Grade 2, the difference, you can pull out the nipple manually, but with less ease than with grade 1. And it tends to retract because of difficulty maintaining the projection. And this then gives an idea that fibrosis is actually moderate, but the difference is this: lactiferous ducts, that are retracted in this case do not need to be cut in order to release fibrosis. However, in grade 3, the nipple is inverted. It's there's difficulty to pull it out just manually, and even if you do, it promptly retracts. Because there's significant fibrosis, there's atrophic terminal duct lobular units, and there's short and retracted lactiferous ducts. So in this case, the soft tissue bulk is quite insufficient. So what are the principles of managing these patients? I would say the main thing you want to do is to grade them, and depending on the grade, it will then tell you what you need to release and to what level. But just generally creating, some level of tightness at the neck of the inverted nipple, using purse string sutures, generally works. Look, additional bulk beneath the nipple may be needed. So after sacrificing the ductal system, you can use cartilage or adjacent dermal flaps in order to add on and have this bulk beneath the nipples. Of course, release of pathological fibrous bands we spoke about, with or without disturbing the lactiferous ducts, you can also do it. But if you have to sacrifice it, I've given you the options of adding the bulk beneath the nipple. And then, of course, recurrence rates are there. They are variable, but they are actually lower when you sacrifice the lactiferous duct. When they are released, although we must know this is going to preclude future lactation, but this is something to discuss with your patient. And I think that handles it. Perhaps a last condition, just know a bit about it, Mondor's disease. What it is, it's just superficial thrombophlebitis in the subcutaneous veins, mainly of the thoraco abdominal wall. And these will manifest actually as a palpable and sometimes actually visible cord that runs from the IMF all the way towards the umbilicus. We know that as, your Mondor's cord. In the axilla, we know it as axillary web syndrome. So this was described by Henry Mondor in 1939, Mondor's disease, and it's just, as we've mentioned, a painful venous thrombosis on the chest wall or the breast. Occurring, our incidents, I think the numbers that I last checked was about 1 to 500 individuals after subfascial implantation, or about 1 to 2% of patients who've received, breast augmentation. So just look out for that. It may be associated the way the patient may present. You may see that cord, or you may see just pain, erythema, sometimes even fever. But how do you treat it? I would just say, generally, we know that this cord resolves spontaneously within 6 months without recurrence. But you can shorten this period to approximately 2 weeks with a single dose of betamethasone. And generally, I would give about 5 milligrams, a single dose of betamethasone. There are other techniques of saying, look, you can use warm compresses, rest, support, you reassure the patient. But if it keeps persisting, you can even actually go in, divide the vein above and below, or just simply excise it. But what you must know, post breast surgery, this is not a thrombotic process. So actually the report suggests that manual rupture of the fibrous band actually ensures immediate functional recovery and the relief of the pain. So something not really to worry about, goes away in 6 months, but you can shorten it. So just be able to recognize it in those patients that maybe you've done inserted a breast augmentation therein. I think we've covered a lot in breast condition, Mondor's disease. We've covered Poland's, we've covered tuberous breast, we've covered inverted nipple, and even hypertrophic nipple hypertrophy, and we've even gone into fibroadenoma and giant fibroadenoma. So that should cover you, really. There shouldn't be much. If there's anything, you just refer to your textbooks and have a look at that. But thank you for joining us for this current talk, and looking forward to the next one. Cheers. 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 Cheers.